Hey there, this is Neil Creighton, and I'm just doing a few educational videos for my patients. I trust that this is a person that I've seen in my clinic, and I've sent you to my website, neilcreighton.com, to evaluate some of these videos on what may be causing your back pain and some of the things we discussed in the clinic, and kind of the process of what's called diagnostic triage of low back pain. I might refer you to a text that I have contributed this chapter to called The Rehabilitation of the Spine, edited by Dr. Craig Liebenson from Los Angeles. It's a very good text. So I said to my lovely wife before we did some of these kind of educational videos online, I said, did you ever think I'd be doing some videotape reviews for people to look at on my website? And she just said, Neil, you're not in my wildest dreams, which I found very sad. If you're not familiar with Winnipeg, Manitoba, which is where I live, this is kind of how we do hot yoga up here in Winnipeg. We're known for outdoor activity. This is July. Our triathlon season is quite slow here, but this guy's very, very intrepid. So I'm just going to go through some simple things today. Some of the diagnostic criteria for what we call ominous back pain, radicular back pain, and mechanical back pain. The idea that what might be causing a pinched nerve or so-called radiculopathic back pain, the common vernacular would refer to this as sciatica. We'll list the potential causes of back pain, and these will be kind of fairly high level, but we'll talk about the disc and the facet joint and the sacroiliac joint as potential sources of back pain. And then in another video, I'll go through some treatment options. So the spinal kind of evaluation and treatment world is dominated by guidelines. Since 1994, with the AHCPR guidelines, there's been publications virtually every year in every continent, millions of dollars spent, because low back pain is such a significant public health problem. Low back pain is the most common source of long-term disability from a musculoskeletal perspective. So we use these guidelines as ways to help our practice, and there's extensive research which has generated the information we're going to talk about today. So many patients come to my clinic and they've maybe seen a different practitioner, and they get a label, something like, I've got facet tropism with an anterior dominant rotation, sacral torsion, my iliolumbar ligament is very tense. I obviously have some multifidi trigger points, and there's also probably an underlying discogenic component to that. And those comments may be true. And then I tell the patient, you have a simple backache. The patient thinks, my goodness, this guy is a dummy. Well, guilty as charged, but I wanted to go through some of the baseline evidence here. So most of the guidelines tell us to go through a methodical algorithm to evaluate spinal pain patients. And it starts with this difference between what we call benign or sinister back pain, sinister or ominous back pain being that caused by cancer, that caused by infection, or that caused by an unstable fracture. We talk about the difference between mechanical back pain, which mostly affects us kind of above the waist in our spine or gluteal area, or radicular back pain, where the pain is really more down my leg in a sciatic nerve distribution. And then we also look at things that are treatable. What can I treat in the office? Where is the person weak? Where does the person have abnormal movement patterns? Where does the individual have muscles that are very, very short or aggravated? So the first part of the evaluation algorithm is to determine whether the patient has a sinister problem. And the first thing we start with is does the person have cancer? This would be less than 1% of spinal pain presentations. So if I see 100 people in a month who have back pain, chances are one of them will have a tumor responsible for their back pain. And some hints to that are that the person does not get relief when they lie down. Most mechanical back problems will be relieved by assuming the supine position. Metabolic features, so fevers, chills, not having an appetite, bladder, bowel disruption, these things are significant risk factors. Pain that's persistent. Most back pain really does wax and wane. It's not there all the time, constant barrage. Things that are not positional, then we start thinking of more a potential tumor-based cause. Again, pain that's worse at night. These represent the useful clues that a person may have a malignancy. Most valuable clue is whether the patient has had previous cancer. breast cancer for women, prostate cancer for men, lung cancer for both. And a person with previous cancer, their risk for cancer being the cause of their back pain goes up to maybe about 9% at original presentations. Pain that hasn't gotten better, people who are over 50, these are important things for us to consider, and they should be part of the evaluation when you see your clinician. The next most worrisome thing is an infection, and most infections are related to either spinal procedures, prior skin infection, prior urinary tract infection, and they're much less common than cancer as a cause. People who have intravenous drug use in their background also have an increased incidence of infection. These are often referred to as spinal osteomyelitis. You can have an abscess around your disc after an epidural injection, either for pregnancy or for pain treatment. People who've had prior surgery can have disc infection called discitis. So again, there are very simple questions that help identify this: fevers, chills, rigors, sweating, weight loss, loss of appetite, fairly typical metabolic features. And then the question of whether you have had a previous recent procedure or a urinary tract infection or a skin infection. A very simple test called an ESR, an erythrocyte sedimentation rate, would be elevated in the person's blood. Their white blood cell count will be up. And if we're really worried, an MRI would be done in this context. Spinal fracture, we get concerned with people who are older and their bones become vulnerable. Maybe a third of women will have osteoporosis and can develop spontaneous compression fractures of their spine. Fall from a significant height, a car crash type of pathology, we would look for spinal fractures. In elderly patients, and I hate to say that, elderly, over 55, up to, say, 6% would have a sinister presentation related to fracture. So we'll kind of go through that a bit more in a different talk. So the first step when you see your clinician is my back pain caused by something sinister, or is it caused by something benign? And that's basically a history is all that's required. I ask you some simple questions. Have you had cancer? Are you losing weight? Have you had a recent infection? Have you had a recent spinal procedure? Have you used intravenous drugs in the previous 6 months? Very sensitive questions. So this is primarily a matter of history. So then we come to this idea of, does a person have a nerve root irritation, which clinicians refer to as radicular pain? The validated physical findings are really only for radicular pain. Many elegant spinal evaluations are done by manual practitioners, but they have a hard time validating them. There's a great deal of inter-rater lack of reliability, lack of validity when it comes to these types of physical exam findings, but not for what's called radiculopathy. We can look at reflexes, we can look at muscle weakness, we can look at sensory changes, and these become very specific in terms of identifying where the pinched nerve is causing a specific radiculopathy. Radiculopathy should be on one side of the body only, and typically just involve one nerve root. If it's not involving one side of the body, both sides, we get a bit more nervous. And when multiple nerve roots are involved, then we typically get advanced imaging because we're worried about something big back there pushing on multiple neurological structures. And you see here this kind of outline around the disc material. This is a cartoon of what an intervertebral disc looks like. And this outside part of the disc here is called the annulus fibrosus. And it gradually starts to deteriorate in the second decade of life. People often ask me, Doc, why do you think I have a disc herniation? And I simply say, because you're a person. And I point to my abundant wrinkles and I say, it's kind of the same thing. I get these probably after I've had some damage to my lumbar spinal annulus fibrosis. The inside of the disc, this material here, is called the nucleus pulposus. It's mostly water with a bunch of chemicals, and it acts as a great shock absorber with the intact disc. When it leaks out this rent or this what's called an annular fissure, then it can create this bulge or protrusion that can push on a nerve. Oh my goodness, there's my leg pain. There's my sciatica. So radiculopathy is usually due to disc degeneration, which is an age-related condition. And these are terms you may have heard. I have a disc bulge, and we see some of the jelly in our jelly donut approaching the edge of that outside part of the jelly donut. Here, the materials come all the way out. It's called the disc herniation, a protrusion even more, so the kind of the vertical axis greater than the horizontal axis. And then here, the material is way out of place. It's separated from the mothership, and these can push on nerves, leading to the difficulty we have with relation to sciatica. I love this analogy of the jelly donut. for patients, and it helps me understand what's going on in my intervertebral discs. Intervertebral discs become degenerate in all people. This is very clearly demonstrated on MRI, often without any symptoms related to the back. This jelly-like material coming out towards the side of the intervertebral disc would be called a disc protrusion. Fairly significant amount of jelly. This is very inflammatory to nerve root, and both by pressure and nerve root inflammation called radiculitis. Oh my goodness, my leg's on fire, doc. Maybe the 5th worst pain people get. Advanced imaging of the spine, MRI here. There's that jelly coming out of the jelly donut at the L4-5, which is the most common disc to become herniated. So vertebral body, the disc material coming back, and it's interrupting all of these structures back here, which are the intervertebral nerves that have come off the end here of the spinal cord. The good news is most of that's gone less than a year later. The body treats it like an invader, essentially. It activates the inflammatory immune system, get rid of that stuff with white blood cells, etc. So if we're asking ourselves the question, does the patient have a radiculopathy, their pain is usually worse in the leg than it is in the spine. It's leg-focused pain. Do I have a pinched nerve, doc? Well, yeah, if your leg's on fire, that's what we're looking for. Again, we look for specific signs that help us get there. Weakness in your leg, sensory loss, loss of a reflex. These things indicate to us that you probably have a damaged nerve or an irritated nerve called radiculopathy. Fairly simple things to go through. May often have a sensory disturbance, and we can see where the pain is in the leg. L5, the most common source of pain over here, lateral thigh, anterior shin, and then S1, mostly right down the back of the hamstring. So L5 and S1 pinched nerves or radiculopathy would account for about 90% of all radiculopathies. Patients often ask me this question, doc, are you going to give me an MRI? And I love this little cartoon about the shy bladder. It's very cute. MRIs have way too much kind of confidence in patients' eyes. The MRI is really a great tool to tell us whether you have something sinister, and that's when it's required. If I think you have a tumor, if I think you have an infection, that's when we should do an MRI to rule out those essentially operative or conditions that will require more advanced interventions. For most back pain, MRIs don't add very much to the evaluation protocol. So I don't need an MRI in that first month of symptoms. I don't need it in what's called simple backache, the dumb doctor answer to what's wrong with your back. I don't need it to confirm a disc lesion. I need it to rule out tumors, infections, and fractures. Again, X-rays and MRIs are not benign interventions. Many people become crippled. Doc, I got a herniated disc. I can't lift. I can't do anything. When that's just not the case. And we know that 67% of people, even under the age of 50, have disc lesions with no symptoms. And we've known this for 22 years since this publication. In the 1990s, MRI was referred to as a terrific test or a tar baby in the New England Journal of Medicine, the analogy being that once you touch that MRI, people get locked onto it. And we start treating MRIs as opposed to treating patients. So the nomenclature, as frustrating as it may be for most of what we see in the clinic, is simple backache, non-specific back pain, or mechanical back pain. The best one is probably non-specific back pain. So most of what happens to your musculoskeletal system we refer to as a perturbation, that the spine doesn't necessarily get injured, it becomes painful. The knee doesn't necessarily get injured, it becomes painful. And these are usually degenerative conditions that have heretofore been asymptomatic, they become symptomatic. So the perturbation with regard to back problems is normally bending forward to pick up a screwdriver or tie your shoe. It's not lifting a fridge. When we get all ready to lift that fridge, we stabilize and support our musculature. And so here's what we commonly see. Doc, where'd my back pain come from? I wasn't doing anything. Nope, that's the usual story. This is the type of cycle that happens with back pain where I have my perturbation, I bent forward to pick up my screwdriver, I wasn't controlling my spine, and I get pain, and that's often associated with muscle spasm or increased muscle tone or whatever term you want to use. the joints don't work perfectly, and that muscle tightness often brings structures closer together. Those are painful structures. There can be inflammation as all part of that, and it becomes this vicious cycle that we need to intervene and break. So the sacroiliac joint can be a source of back pain, this big rugged joint at the back of the pelvis, and people point to it here. If you're pointing here, this is called the Fortin finger sign, and it's probably the major validated clinical sign for pain emanating from the sacroiliac joint. Maybe 10% of pain based on numerous academic interventional studies can be ascribed to the sacroiliac joint. The zygapophyseal joint, these little up and down joints in the lumbar spine that would be like dimes rubbing together. These are true synovial joints with a synovial fluid around them. They can become inflamed. They can become disarticulated in some ways. They can become pain generators. They're often referred to as the zygapophyseal or facet joint. Maybe responsible for 20 or 30% of pain in the spine. In the neck after whiplash, they're responsible for probably 50% of chronic pain. And this would be the C2-3 facet joint leading to pain here. I'm very interested in this area from research on concussion, which indicates that headache in concussion often comes from the upper cervical spine. So these are patches of pain an individual may have when their facet joint has been irritated in the neck. In the low back, the cartoons show, again, here, any in this region can be from specific zygapophyseal joints that are irritated or perturbed or symptomatic. Again, disc disruption can be what's called internal disc disruption. Here you see none of the juice has squirted out of the jelly donut, and this would not appear as a disc herniation, would definitely not be visible on plain radiographs, but may be missed by some CT scans or MRIs, not even commented on. And this internal disc disruption is a frequent pain generator. So we won't get into too much of the examination of patients for back pain. We really are interested in these ideas of sinister features, radicular features, sometimes non-spinal causes. Belly pain, abdominal aneurysms can be responsible for back pain, gallbladder disease, ulcer disease. Again, your clinician should talk about that. And then we look for spinal causes, and we look for functional deficits that can be treated. So this is kind of some of the complexities behind looking at your spine, what may cause your back pain. And so your clinician should be going through, do you have a sinister problem? Is it a tumor, an infection, or a fracture? Basically from simple historical questions that your doctor or a clinician would ask you. And then we would say, does the person have any nerve involvement, so-called radiculopathy? Physical examination, very sensitive for that. If you don't have a tumor, infection, or fracture, you have benign-based pain. If you don't have nerve damage, you have non-specific pain. So people have so-called non-ominous, non-specific back pain. Not a very gratifying answer for your pain complaints, but it is an evidence-based answer. In the next series of videos we're going to do, I'll go through some simple treatments based on some paradigms in looking at what might cause back pain.